So we do have a number of us together now as a group. We have a great group, and we'll showcase everybody today as we go along. And we talked about this, the fact that why are we all here? We're here because we have so many hips and knees to do. We got a lot of work to do, okay? In the next 15 years, we'll be up to 3.5 million knee replacements. There's a lot of interest in this because it's going to be a big business. On the other hand, we have to make sure we get paid for what we're doing. So it's kind of a balance of everything. This is the reason why that they're kind of getting very, very nervous in Washington, D.C. because the boomers are coming, and they've exploded the grade schools years ago, the colleges, the job market, and now they're going to go into the hospitals and rehab centers. So we have to figure out how to deal with all this. Our pathway started a long time ago, and we always wanted to focus on the patient. And then we have the doctor-patient relationship, and then we have the hospital that goes along with that. Then we go out to the rehab centers as we go, the VNAs, and outpatient therapy. So this is all this. This is why we have all you in the room here, so we can work as we give these concentric circles of care, and as it expands, just as you throw a little pebble into the pond, we all kind of have to work together. It started in 1995, working together. It was actually brought together. You may remember Carol Delaplane. She was vice president of nursing at the hospital, and she got the whole thing going. We started off with hip and knee replacements, and we've also added fracture hip and total shoulders. And now we've had probably, I've estimated, at least 10,000 patients actually go through our pathway. Along the way, we've gotten 5 stars for many of our programs, and 2 years ago, we were actually told, Dr. Zabilski referred to it, but it was actually known that the Medicare data showed that we had the fewest complications of hip, knee, and shoulder replacements in the state out of all the 60 hospitals in eastern Massachusetts. So we did something right, but how do you do this? Well, we have to get a lot of people involved. These are all the people's names, and if I kept your name off of it, I'm sorry. But anyway, these are all the people's names that we deal with, and it goes from, the beginning, pre-admission, orthopedic visiting nurses, anesthesiologists, everybody along the whole way, pharmacy, physical therapy, social service, and of course all my nurses. And how does this work? We start with a monthly orthopedic pathway meeting. Once a month, Melissa Killam gets us together, and we meet together, and we have everybody who's involved with our pathway, all the way from soup to nuts, starting with the nursing staff, OT, PT, anesthesia. We have the hospitalists there, infectious disease, the orthopedic surgeons. And again, we're just part of this whole process as we go along the pathway. And then we have our agenda. We talk about new medications, and they don't like surprises, I found out. They usually say, "What are you doing now?" When I woke up on the floor, there's something different, and it's kind of fun to see if they see something that I'm doing different. Then I have them kind of guess what we're doing different and why that patient's not having pain, or why they're getting up, or what this dressing is about, and who did you go through the right group of people before you got the dressing okayed. But at any rate, we do these different things. We also we review all our readmissions. I like to know why something didn't work. And so if something didn't work, I want to know why. And if something bad happens, I always say we have to have something good come out of something bad. So we review what happened, and we make sure it doesn't happen again, or figure it out. I put down challenges. We kind of challenge ourselves. I mean, for example, we don't have Foley catheters anymore for hip replacements. I mean, this is something we just try. We look at what we have done traditionally for years and challenge that idea and see if that has to keep on being done that way. I mean, do we have to always have general anesthesia? Can we do something different, a different way? Can we make it better for our patients? And I mean, do you just have to keep doing the same old thing? So, that's been very good for us to keep on looking at what we can do different. So what's a pathway? It essentially is a plan to standardize treatment for patients with a specific diagnosis. So let's take a tour of the pathway. It starts with a phone call. And you have to get past Janet at our front desk there, okay? It starts with the appointment and a history examination, imaging, discussion. We look at imaging, and if we can't figure it out with an x-ray, we go ahead and get an MRI and we figure out the diagnosis. And the doctors have already gone through how you take care of these things with medications, injections, working out, activity modification. And sometimes, unfortunately, you have to be quite blunt and just say, you have two problems here. You have a weight issue and you have a knee issue. And we have to take care of the weight issue first. So we have to, help out our patients, and that's one way to help them by being honest. We talk about surgery if it's necessary after failure of conservative management, and we go into we talk about their issues and what I'm worried about as a surgeon. If it's whether or not it's their heart, if it is their heart, then we have them see their cardiologist. We talk about their anticoagulants because that has to be kind of monitored, whether or not they have to be on some sort of bridging medication around the time of the surgery. Surgery is scheduled through Trish, and you have to get by her as well. I have all these people who kind of like, you have to kind of get through this. This is that pathway, it's a lot of hurdles along the way too. We have a joint class, and that joint class has been very useful for our patients. They many times will bring the family with them, and that's been great. Melissa and Sean run that, and they've done a wonderful job, and all I always hear is great things about that. So thanks very much for that program. From there, they go to a pre-op admission testing. They do intake information there. That's going to be key. As we talked about, we have to do the medical examination as well as cardiology. Blood tests, urine tests. The MRSA program, we've taken that program from the Baptists. The Baptists actually did a great job in getting the MRSA program set up, taking cultures from the nares and seeing if a person is positive for MRSA, and then that leads into what our choice of antibiotics is. And that's been very great in decreasing our rate. We were the first community hospital to pick that up, but again, we took it from there. It's always good to look around and see what other people are doing if it looks like a good program. We also have them talk to the anesthesiologist. In this case, our nurse practitioner. One thing that's been really useful, and it just came out this month actually in Journal of Bone and Joint Surgery, is prehab. And they find out that prehab is great. It decreases costs. It decreases the amount of physical therapy a person needs. And over and over and over, I'm sure there's a number of physical therapists in the room. They see our patients doing so much better after surgery. And this is part of the program too. So we do have them involved. And it would be better even to have them do that for a number of months. Not always under the visual guidance of a physical therapist, but at least to get the instruction and then have them perform it if they're able to. Unfortunately, some of these patients aren't able to do the physical therapy program, but nonetheless, it's good to do that. The surgery day. Holding area, as you know, we have to mark all the patients. We now have something called the Bergeli antibiotic pathway. Jimmy Bergeli will be speaking this afternoon, and I do put that in kind of tongue-in-cheek, but he brought this new idea, this concept that each person has to be kind of reviewed very exclusively, along with that intake information by the nurse, and by giving that information, all this is now computerized. So actually, this whole antibiotic choice is picked out after you give the information, and it's been working out great. We, at that time, give all our pre-op meds, and we use a multimodal system that Jimmy will be talking about later this afternoon. And all these medications are given right in the pre-op area, so then we can go in the operating room and perform our magic, or whatever. But before they go in there, with the knee, for example, we use something called a femoral nerve block most of the time. The femoral nerve is a little nerve that is right on the front of the anterior thigh area. And what's done is it's a sensory nerve. It goes down the leg. It goes down to about mid-tibia, mid-shin, and it also, unfortunately, blocks some of the muscles of the leg, the quadriceps. And what they do is very skillfully, they put a needle into that area using an ultrasound technique. And this is the area where the anesthesia occurs. And if you're a nurse, you know that they can move their toes, but they can't lift up their leg. They can't straight leg raise. And this is the reason why. This is the area of the femoral nerve. We've been using this, but we're minimizing it so this way the patient can participate in the physical therapy program as fast as possible. The other thing we've been using and pushing really hard is spinal, because this has been very useful for our blood management, both in our hip and knee replacements. We have less, we do have, what happens during the operation when you have a spinal, it decreases the blood pressure, therefore we have less pressure in the operative wound, therefore we have less bleeding. We also have, we found that we have less cognitive issues post-op. And so I've been gently steering a lot of my patients by gently saying that they'll lose less brain cells if they have spinal anesthesia than general. So they don't have to do as much Sudoku later on. I've been working with tranexamic acid, and the hospital pharmacist essentially required that I do a study on this. This is a medication which is interesting. What it does is it somehow interferes, and I'm sure as an orthopedic surgeon, we're not very keen on understanding drug interactions and everything, but somehow it prevents some of the plasmin receptor sites from carrying on and breaking up fibrin. So essentially, it holds the fibrin together so you have less blood loss. And it's been helpful. The study that they did was with 50 patients at our hospital, and it showed that there was, essentially it didn't show that much great effect of it, but anecdotally it seemed to help our patients more. We've had certainly less blood transfusions over the last couple of years using this. We're now working on getting this topical. What it does is it does tend to clot blood, and so you wouldn't want to use it in people who've had cardiac stents or they've had a history of stroke. So we're now going to try to work and see if we can get this available to us or topical right in the wound itself, and we'll see how that works. So essentially, as I said, the tranexamic acid prevents the fibrin breakdown. Exparel. This was a game changer for me. About last Thanksgiving, I walked up to one of my friends, Joe, or a patient of mine who I knew socially, Joe Gillis. I said, Joe, I need a guinea pig. And he's in pre-op holding, and his eyes about bugged out about this big. He said, a guinea pig? I said, yeah, I know this will work, but I need someone to allow me to put this medication in their knee after the surgery. And he says, you think it's going to work? I said, I'm really sure. So I actually happened to see him the other day because he's coming in for a second knee. He wanted to wait a year because this was the right time of year for him. And I said, so what do you think, Joe? Looking back on the whole thing, did you mind being a guinea pig? No, he says, I knew that, I figured that you had thought about this long enough. And he said, it really worked. I was home, and he left after 2 nights in the hospital, and he's coming back for a second knee. So he was excited about it even a year later. So we did do it. It was the week of Thanksgiving, so we're coming up again. But at any rate, it's a long-acting bupivacaine, and somehow it binds with the fat tissue, right? I would like you to all talk to the Exparel people out there to understand exactly how it works. But at any rate, it does give a slow release, and it does seem to work. And the nurses on the floors will tell you that it does seem to work great for our patients, decreases their pain, and consequently, what happens is that they just move along faster. We can move our patients along faster. Pacira did their own study, and unfortunately, we don't have more studies outside of Pacira just sponsoring their own studies. And this study right here did show that overall, that it was very beneficial to patients, both with pain, range of motion, and a shorter overall length of stay. So we're going to continue to use this, and Dr. Zabilski and I have both been doing this. And of course, it's like anything else. If I always say if you have 10 orthopedic surgeons in a room and ask their opinion, you usually get about 12 different answers. So Dr. Zabilski and I both have our own technique of doing this, but nonetheless, we've been finding it's been very useful for our patients. Also in the hospital right now, we still, as Dr. Zabilski did talk about, we still are using our navigation. We kind of pioneered this down here. And we started doing this in 2003, and now we are kind of masters of the trade of using these computers. How do you handle pain management after knee replacement? Well, we've been doing different, the word is trials of patients. We've been using OxyContin on patients. We tried it and used it in older patients. We did have some major cognitive issues with that, and so we backed off of that, and now we use it for patients 75 and younger. We've been using quite a bit of Percocet and Vicodin, and again, the Vicodin. The Percocet just has some issues, so we just primarily use the Vicodin as people get older. Celebrex we've been using. The problem is with Celebrex, you can't use it on everyone. There's for patients who have self-allergies or cardiac histories. The Celebrex, by the way, is going to be coming generic January 1. So that's going to kind of be a breakthrough for everyone from that point of view. So we've been using Tramadol too. I don't think there's a lot of pain relief with Tramadol, but it's enough that it seems to be more than Tylenol. And the only problem is that it's just starting to get to be shown to have some addictive qualities. So now it's a controlled substance. And I have to be a lot more careful about how many prescriptions I give of this medication overall if they still have some degree of stiffness or pain. One of the things we'll be talking about today is the IV acetaminophen. That's been working out great. In the past, we did try Neurontin, we did try Lyrica, and we didn't have enough, didn't seem to really have worked that well enough to continue to be part of the pathway, so we stopped using it. Some of the patients, I remember, had some double vision. They kind of look at me and couldn't get their eyes straight, with the Lyrica. So, things like this, we want to make sure that they don't see two walkers, just one. So. You may have also noticed that we don't use the CPM anymore, and I think that's relative to the fact that we have pain relief, and most of the time it's pretty amazing. We actually have a range of motion from 0 to 90 almost within 24 hours of doing these knee replacements. ICE seems to be in, and the Bragg people are here today, and they can show you the ICE machine that we've been using. It's been working out great. Some people swear by ICE. I happen to be one of those people. We have a lot of people who don't like ICE, and it's a personal thing, but it certainly seems to decrease some discomfort, and most patients seem to tolerate well. One of the problems we have with surgery and medications is postoperative nausea. We've been using a lot of Zofran. We've been using scope patches on patients pre-op, and if necessary, in the really, really tough cases, we do use steroids. Overall, so we've got that reasonably under control. This is a hardy group of people, and these are the people that, wonderful women who are your angels, who take care of you. But at any rate, these are the nurses, and they take care of them, take care of your stay at the hospital. They've been doing a great job for us. The question we have then is home or rehab, and most of the time right now we're pushing home as much as possible for all the different issues that are going on financially. VNAs, as you know, we use Coumadin. The reason we use Coumadin is because it's reversible. Lots of these new medications that are coming out are not reversible, so I still favor warfarin, even though it's difficult to manage. We have to deal with all our busy nurses calling us up after their INRs twice weekly. Incisions, we've been using silver impregnated dressing. It's kind of controversial as to whether or not it's necessary to use the silver or not, but it does seem to work. We use the waterproof type so that they can take a shower. We peel it off after 10 days and then take out the staples. With my hips personally, I'm using no staples or sutures, and that seems to be working great. With the knee, the problem is, the question is, what do you use, staples or absorbable sutures? And my problem is that using the knees being such a joint which has to be moved through the process of therapy and everything, I've had some issues of dehiscence of the wound, so I've stuck with the staples at this point. I'm still waiting to see if there's something called barb sutures or things like this, so people are working on a better technique for closure, and we can take a look at that later on. At the 3-week post-operative MD appointment, essentially, you do have to look at the whole person. We do, it's a big hit for a lot of people after having a hip or a knee replacement. And so they'll lose weight, they just won't look good at the 3-week mark. And, and they sometimes will have a readmission for some other issue. Diverticulosis we've had, or things like this will happen. So you do have to kind of look at the whole person. You also have to look at the caregiver. The caregiver many times will be totally worn out. And that's, you kind of have to assess the whole picture of what's happening with this patient and how can you help them out. We do take care of them from the big picture. That's important. Outpatient therapy is useful. We get that going. The 6-week follow-up is independence. What we do is they did come out with a paper finally that I saw that said that it's appropriate that the reflexes after an operative right hip or right knee comes back about 4 to 6 weeks after surgery, so I now have at least a time frame that I can give people. With the left leg, I usually tell them that as long as you're off the narcotics, you can start thinking about driving after 3 weeks. But the right leg, you tell people to start driving on the secondary roads and not stay on not get on the major highways for a while. So after that point at 6 weeks, when you're sitting around like this all the time, it's time to Zumba. So we get the girls going, we get everybody going, and it's time to go to Florida or wherever they're going. I like to have people stay in this area for at least 6 weeks because that's where all the major issues can come back, whether it's a DVT or infection or cellulitis. Most of the time, just minor stuff. But the things that you do want to be there for them during that period of time. I think the important part of this is the fact that we do have so many returns. I mean, and that just says something right there, that we do have, you do see the fact that they say 80% success rate with knee replacements, and it seems to be higher with hip replacements, but the fact that people come back for the second joint is just showing the fact that we're doing a great job, and it shows the success of our program. So the big question is what's happening right now? Are we all going to be employed? What's in our future? What's in the future? So I think just kind of looking back, I was trying to be kind of philosophical about the whole thing. Is where are we at right now? And what are we planning on doing? And just kind of thinking about it. The techniques, we're going to have improved pain management, but we also need to have improved edema, soft tissue control. I was just spoken to the Breg rep, and I said, what we need? We need an ice machine with a compression machine at the same time. So you have that ice going down the whole leg. And I said, let me talk to your patent attorney, we'll work this out. But I mean, that's what we need, something like that really controls that edema and swelling and everything. And we do need something we do need that magic bullet they talk about. We need a pill that takes care of anticoagulation for us so we don't have to continue to monitor it and yet at the same time have it reversible. Because the last thing I want to do is have someone be on a medication that they can end up in the emergency room with some degree of bleeding and we can't control it. So we need to have that magic bullet that we're working on. So Jimmy, work on that for me. Technology, as the doctors were talking about, fixation. Most of the time we are using cement with all our knee replacements, and that's a major issue. We need to have better fixation. One of the interesting things that's going on right now is robotics. And Dr. Reitmeyer is talking about the fact that robotics are here and they're going to stay here for a long time. This seems to be the wave, and it's going to be based on some sort of image, whether or not it's a CT scan or MRI or some type of new image where you actually use a robotic technique and then do your surgery. And there's going to be a continued evolution of the prosthesis, even better. I love my knee replacement. I like the hip replacement. Everything seems to be working, but I know that we can make this even better from here. Economics. What you're going to do is you're going to start seeing more prosthesis selection according to the patient. Does the patient who's 85 years old need the same type of knee replacement that a 50-year-old needs? I mean, we're going to be seeing that sort of selection process going on. We do already now do it with hip replacements where we use a ceramic ball versus a metal ball. The ceramic ball would be in a younger person. Aligned incentive, something's coming up right now, it's called bundled payments. We're all going to get one big check and we're going to have to figure out how it's going to be divided up. And that's going to be a big deal. That's going to lead into day surgery. And then lastly, the big picture is down here, we're dealing with BID Boston and then the New England Baptist, and how are we all going to fit together? That's what the issues that we're dealing with right now. So those are all the different things that are coming up right now. So I would like to thank the patients that allowed me to take pictures of them and the nursing staff as well, who are all part of our program. I do really want you to take time, and I will tell you again, please take your little brochure there. If you get signatures from all your sponsors, give them to Claudine at the end of lunch, and then you can get a raffle to the free iPad. And lastly, I would like to thank all of you for being part of our program and being so successful. That's why we're all doing great. And these T-shirts will be coming back, just with a different name. We'll make sure it happens. It's really kind of cute. The patients come in, they're very proud. At the 6-week mark, they have their T-shirt on, they're smiling, and they're walking around and as if they're a graduate of the program. So somehow we'll get these T-shirts going again. So.